Good afternoon, everyone, and welcome to this, the second webinar in our series exploring long-term conditions and improvement within that field. My name is Richard Taunt.
I'm Anna Hulls. I'm Annette Jack.
And delighted to be joined today from Hershey, Pennsylvania. It's Erin Moore. Erin, good morning.
Good morning.
You were saying you didn't bother to stay up all night and follow the election results.
That's right. I had this to get ready for.
Yeah, more important than midterms. Erin, thank you so much for joining us. I'm looking forward to hearing from your experiences later on. It's symbolically, so we're coming to you today from Kaleidoscope HQ, which is in South East London. The moment we hit start broadcast, the sun has come out. So we're going to treat that as an omen for the next 58 minutes or so, where we're talking about long-term conditions and particularly the role of patient leadership within that, and how we can go beyond all nodding and agreeing that that's a good thing, to how patient leaders can best be supported as an integral part of improvement. So we're going to be hearing from Erin. We're going to talk a little bit more about the background to the series in just a second, but just to say that this is very much a discussion. We'd like people to join in. Anna, how can people get involved?
Absolutely. So you can join us in 3 ways. You can either post a question using the question box facility on your screens. You can join us on Twitter via @KScopeHealth #long-term conditions, or if both of those fail, you can email us hello@kaleidoscope.healthcare.
Thank you very much. And if your IT suddenly decides it wants to have the afternoon off, and you are unable to join us for the whole thing, don't worry, this is being recorded, so you'll be able to watch later. If you are watching later on, welcome. Probably that ask question feature isn't going to be quite as useful, but we'd still welcome your reflections via email or Twitter on our discussion today. Thank you again for joining us. So just to give a bit of context to what you've stumbled into, today's webinar is a partnership between Kaleidoscope and AbbVie. So Kaleidoscope, we're a social enterprise focusing on bringing people together to improve health and care. And we think a lot about our work being to support the conversations which need to happen, but often don't, whether that's sort of across different regions within the country or across whole continents such as today. And we're delighted to be working in partnership for this event series with AbbVie.
Yes, thank you, Richard. So for those of you who don't know, AbbVie is a pharmaceutical company. We were founded in 2019, and we
2019.
Oh, sorry,
it's coming.
Oh, 2013. Imagine I'm seeing into the future. 2013, and we develop innovative medicines for areas of unmet need. However, whilst we're really proud of the work that we do, we know that we are only a small part of a huge health and care system that is working to deliver the best outcomes for patients. So that is why, as part of our Sustainable Healthcare Initiative, we work with organisations and individuals across the health and care system to find and spread new innovative ways of delivering the outcomes that patients both want and need, and also ways to ensure that the healthcare system can remain sustainable to do so. And this series of events is just an amazing way for us to hear from people like yourselves who have joined, wonderful people like Erin who have taken the time to speak to us today, so we can learn from all the hard work that's going on out there and find out how we can do more of it. That's us.
Thank you very much. More future predictions welcome.
Yes,
later.
No, anytime.
Why just look at the past? Let's look at the future as well. Annette, thank you very much indeed. So just to set the scene, that this is, as Annette mentioned, part of a series which we've termed Change in a Cold Climate, particularly for fans of Nancy Mitford books, but also because we are wanting to talk about change and long-term conditions in a more realistic way, possibly than often it is. We know that change in the NHS in 2018 is difficult. I imagine it probably is difficult in Hershey, Pennsylvania as well. So what we're really wanting to think about is sort of how some of that nitty-gritty of how change happens, some of those practical examples of change and what really sat behind the improvements where it's been made. So why are we focusing on this? Well, this is a big quote which we use from the US economist Paul Krugman when talking about the economy that he says that productivity isn't everything, but in the long run, it is almost everything. In healthcare, it's pretty much true. You can just delete productivity and just put in improvement. So we often talk about our system being underfunded and the need for more funding. Yes, that's true, but unless we're actually able to improve our system, improve its ability to deliver the outcomes which matter for our patient populations, then in the end we will be lost. So it's sort of fundamental that we think about how we improve, And a particular aspect we've honed in on this series is that if you look across the NHS, only 55%, so just over half, of staff feel they're able to make improvements happen in their area of work, which we find is actually sort of quite, if you reflect on it for a second, quite telling. It's barely budged within 5 years. And if we just think, if that figure was 90%, if 90% of staff felt empowered, had the agency to make change their area of work, what would the NHS look like then? That's some of the ideas we're trying to get into in this series. We're particularly talking about long-term conditions, chronic conditions, if you're coming to us from a slightly different place, where we talk about this a lot, and you've probably heard a number of statistics, such as there are 15 million people in England with at least one long-term condition. So you can play bingo now here. Have you heard that statistic? If you have, give yourself a tick. You might well have also heard that 50% of all GP appointments are for those with long-term conditions, and that 70% of the primary care budget in England, roughly, is spent on those with long-term conditions. So we do talk a lot about the scale of this problem, and that, or not necessarily a problem, scale of this challenge, and how we best face it. There's another side of this which we talk about less. So if you look at international comparisons, there doesn't appear to be any country which has cracked long-term conditions care. And so if you look at international surveys, such as conducted by the Commonwealth Fund, so this is a survey which looked across a whole range of countries, looking at adults with a chronic condition, long-term conditions, that did not discuss with a health professional treatment options, including side effects. So you would think, actually, having that rounded conversation about what might be some of the side effects of a treatment for a particular condition would be a fairly fundamental part of a patient-centered approach. But here you can see, no one particularly faring well. So this did not discuss. So you want the figure to be low. So Australia, no, is doing not too badly. It's only a quarter, didn't discuss. Norway, Sweden, normally we look to Scandinavia as having all the answers a bit higher. So this isn't an area where any particular country seems to be massively outperforming any other. Well, this is looking across countries, of course. We might want to look at Hershey, Pennsylvania as a small unit, and Erin, you'll tell us that you have completely cracked it. So we'll come back to that in a second. Unheard statistic number 2, we talk a lot about long-term conditions as a singular condition. We talk less about multimorbidity, people living with multiple long-term conditions, although thanks to the great work of RCGP, the Richmond Group of Charities, and others, Guys and St Thomas's Charity, we are starting to talk more about this. But we know that those with living in the most deprived areas are affected by multiple conditions 10 to 15 years earlier than the general public, than the overall population. And so that there's a real health inequalities aspect to this, which we possibly talk insufficiently about. And finally, it's that anniversary again. It's 46 years and counting since the 1972 white paper. It was called the NHS Reorganisation White Paper. We don't call them like we did any longer, which famously said there is a need for far more services that support people outside hospital. Often, what there is could achieve more if it were better coordinated with other services in and out of hospital. This came from a government paper in 1972. You can pretty much cut and paste it into any government document in that 46 years since, or even now. We have the 10-year plan coming up. It probably will say something very similar. So there does seem to be an issue that we talk a lot, but possibly the changes that we hope to see aren't happening quite as fast as we would like. So brings us round to today. We do need new insights. And particularly today, we want to think about how can we learn to meet, how can we gain learning to meet these challenges, improving long-term conditions from other contexts and particularly what can we learn from high-performing healthcare systems elsewhere, and this particular focus on patient leadership. And so that is a very lengthy introduction to say, Erin, we're delighted that you're able to join us today. I'm sure we'll be talking about the Cystic Fibrosis Learning Network you've helped to found in the US, which we work with a lot of networks here at Kaleidoscope, and we study and try and understand what they do well. The CF, the Cystic Fibrosis Learning Network in the States, is one of the top tier networks which we look to and get, well, if all networks were like that, the world would be a much better place. So Erin, I think you're going to talk a bit about the CF network, and particularly your experiences and your role as a patient leader within that context in driving improvements for children and adults with cystic fibrosis. That is quite enough of me. Erin, over to you. Thanks so much for joining.
Of course. Good morning or good afternoon to everybody. I thought I would start by telling you a little bit about myself before I get into my story. My name's Erin Moore, and right now I'm working as a family leadership coach with a quality improvement consulting firm called Shift, where I really focus on bringing the perspective of parents and family members into improvement work across a number of different collaborative innovation networks. So I'm working on a home visiting network where we focus on things like maternal depression and breastfeeding and intimate partner violence. There's an education collaborative, and then most importantly to me is the Cystic Fibrosis Learning Network, which is focused on improving care and outcomes for people living with cystic fibrosis. Before that, I ran the digital marketing strategy for Eli Lilly on their clinical innovation team. And before that, I worked as an e-patient advisor for them, where I partnered with their communications team to inform different communications efforts to ensure that they would resonate with the patient community. Before that, I was on the FDA's Pediatric Advisory Committee and worked as an FDA patient representative to provide a consumer perspective on issues and actions that were brought before the FDA for review. In 2015, I was working with the Robert Wood Johnson Foundation on their Data for Health initiative, where we were working to create the framework for how diverse sectors could better collect, share, and use different health information to improve health and promote wellness in the country. In 2012, I started working as a family partner on the pulmonary clinical care team at Cincinnati Children's Hospital, where I was collaborating with the clinical staff to ensure the perspective of patients and families was represented, and working really to develop solutions to bridge the patient and clinical communities. And before that, I had a son who was born and diagnosed with cystic fibrosis. And before that, I was a normal person. So that's really where my story begins and the reason why I'm here today. I'm a mom, first and foremost. I have 5 kids, and one of them has cystic fibrosis. He's actually one of the middle 2, they're twins. And in 2010, we didn't know anything about cystic fibrosis. He was born, he ended up going immediately to a children's hospital. And I just remember feeling, I didn't know anything about this disease. I was scared, and I felt a desire to do something, I think as most people would, especially a mother of a newborn. But I didn't know what I could do. I didn't have any knowledge of cystic fibrosis. I didn't have any experience or expertise in healthcare other than what all of us have experienced kind of casually. And I quickly was introduced to the Cystic Fibrosis Foundation, an organization that's based out of the US here that empowers you to fundraise. The cystic fibrosis is a pretty rare disease. There's only about 30,000 people in the US and maybe 70 or 80,000 people worldwide. But we are responsible for raising the money that funds the research for all of the drugs that we've created to date. So they empower you to fundraise, they connect you with other families. And over time, I started learning more about the disease just through our experience, how it was going to fit into our life. Our life was not over. It was very livable. It was still scary. But then about a year, when we finally came out of the fog of diagnosis, I learned about the Patient and Family Advisory Council at our care center. And I was invited to join this, and I remember going to a meeting, and I quickly realized that they were trying to solve the problems that they thought we had. This was the clinicians and the social worker and the nurses and dietitians. They were trying to create solutions and get our feedback on the problems that they thought we had. But I wanted to be a part of not just focusing on the problems, but helping to identify the things that were really, truly, struggles in our lives, and creating solutions to help address those problems. So I started working with them a little bit more and got to experience a more comprehensive understanding of how we were all approaching this disease and how complementary our work was, but how misaligned it often was and how much frustration and burnout that caused. And in doing this, I just couldn't shake the feeling that there had to be a better way to work together. So I learned about this learning health systems model and some learning networks that were being built out of Cincinnati Children's. And I had a strong desire to create one for the CF community. It was patients and clinicians and researchers all working collaboratively to improve care and outcomes in a number of these other diseases. And folks thought that the cystic fibrosis community sort of already had this. We had a care center network, we had a registry, we have this patient network, but we still weren't seeing improvements in outcomes. And that's what I was struggling the most with. So I didn't understand anything about quality improvement. In my former life, I had been in marketing, but I realized that if we could better understand how actions impacted outcomes, we could change the trajectory of this disease, learning and improving faster, which is so critical in a disease that's both progressive and fatal. None of us had time to recreate the wheel. So I have to say that I was really a minority in this group, though. There were teams of clinicians and researchers, but for a really long time, I was the only patient caregiver. And when I would challenge their assumptions or raise uncomfortable conversations, I was always alone, and I was sort of expected to be grateful for what I had been given, the opportunity to work with them. This collaboration of like this multitude of stakeholders, and I just couldn't shake the feeling that I could be both grateful for what I had and continue to push for what I still thought we needed. In this kind of feeling unheard or invisible or resisted, I stumbled upon this great article talking about ownliness and what we each uniquely bring to the world. And in this article, there was research focusing on this feeling of invisibility that was described by two researchers from Columbia University about how power and status act as self-reinforcing loops. So how much status a person has directly affects whether their ideas are heard. So for example, if you're high status, like the boss of the PTA or the chief of surgery, you and your ideas are met with greater receptivity starting early on, and thus you get the emotional support to develop these nascent ideas into more complete and robust ideas. That in turn leads to more, that in turn leads to more results, which then further boost your status. So equally, if you're a person of relatively low status, like a patient, because you lack pedigree or credentials, or you're old or a woman, the likelihood is that you'll get none of the same support. So for me, this was a huge aha moment, finding this article, because there's no power differential quite like that between patients and clinicians. We've been historically expected to just be passive recipients of care, but in this information age where we are informed and connected and engaged and empowered, we're coming to the table with complementary knowledge and expertise through the value of our the value of our experience is often seen as something less than in the clinical setting, less than clinical training or credentials that our clinical care partners often have. And when you lack that status, you're likely to be told that your idea is too risky or too weird or too far ahead of the times or whatever. The problem with this was, like the article stated, that you're then rendered invisible. So I was just regularly and repeatedly being rendered invisible. And it wasn't because my ideas were weighed and deemed unworthy, but because it came from somebody who was deemed relatively powerless and therefore unworthy of being seen or heard. But I knew that these were useful, valid, action-worthy ideas because I was the one who was living with and caring for a child with this disease and interacting in these disease communities where so many other people were also desperate for change. So after this aha moment, I realized that if I was going to make a difference, I really had a lot to learn. And I needed to find other people like me to get them onto my team. And so I slowly started to find people who were on the fringe, who were frustrated with the status quo and impatient with the pace of change. And as I found partners, we started to become exponentially more powerful. And by that, I mean, it was harder for people to ignore us. The other thing that finding these partners did was it gave other people permission to join. So, you know, as the lone nut, if you will, people didn't want to interact with just me, but when they saw I had a follower, a partner, it made it less risky for them to participate as well. People don't always follow the leader. Many times they follow the followers. So it gave other people permission to kind of participate. And slowly we started to build up the capacity of patients and parents in the conversation about improvement. Our expertise is really unique, and we're uniquely qualified to represent, excuse me, the lived experiences of people within this system of care. It also changed the conversation about what we were trying to improve. So the clinical partners wanted to see improvement in areas like lung function or BMI, but for me it was about quality of life, because living means more than just being alive. It was something so simple, but something that they weren't even considering before the voices of this critical stakeholder group was present. This perseverance eventually built up a group of nearly 70 parents and patients now that's working collaboratively with 27 clinical care teams nationwide that are focused on improving care and outcomes for the CF community. Excuse me. We are, clinicians are now inviting our feedback and input and asking for our collaboration rather than resisting it all the time. I will say that most of these parents and patient partners in our network are paid in some capacity for their contribution. We still have a lot of work to do here, but you know, no one else was coming to the table as a volunteer. And if we wanted to create this foundational partnership, their expertise really had to be appreciated and valued as equal to the clinical care teams. We created a QI learning curriculum specific for patients and parents that is free and available to anyone that was interested in learning and testing out how their ideas might impact the outcomes that we're working to improve. We really needed a shared language to use with our clinical care partners, a way to align on our goals and the steps we would take to get there. And we're really making great strides in doing this. We just finished the 3-year pilot of our network, and we received funding to continue to grow and scale the network across the entire CF community so that we can finally start to see the transformational change that we also desperately need. I think most importantly for me, I believe that having a place to make a contribution moves parents from this post-traumatic stress of diagnosis and disease progression into like a post-traumatic resilience. People want to contribute. I cannot tell you enough. People want to contribute. And it makes them feel good, and it can change the trajectory of their lives living with these chronic illnesses. There are so many well-intended improvers that work so hard to create solutions for others rather than with others. And for me, in my experience, this is where time is wasted and inefficiency is really recognized. People want to contribute their ideas. They just don't always have a place to do it. So if I can offer you one bit of advice, it's to create that space for them, create a receptacle for people's ideas and learning that they want to give to you, and work to partner with them, even if it's challenging, because the rewards are really great. Just to kind of wrap up, excuse me, I jotted down a handful of what I would call lessons learned through this work that I thought might be useful to share with you. The first is that patient leadership is really challenging. I've experienced all kinds of burnout and resistance and you name it. Very few people appreciate or accept that your experience can be your expertise. But I encourage you to think about that and see in other areas of your life how that might be true, and work with patient leaders to kind of find ways to invite and accept this in. The next key lesson learned, I think, is that you can often learn the most from the people who disagree with you, even and perhaps especially for the people who are most unlike you, whose ideas are in conflict with yours. but you can't lose sight of the fact that you're all working to the same end. And there are lots of ways that you can get there. There's not one way to do anything. It's hard to do this work with people who are not like you, and it's important that you find a shared humanity. So an example that I might give is if you're sitting with your doctor, rather than thinking of yourselves as doctor and patient, are you both parents that spend Saturday afternoons at soccer games? Or do you share a love for dogs? Are you both caring for aging parents? We realize when we take a step back that we have more in common with each other than not. I think the next lesson is that all people who are going to be a part of your system should be involved in helping to design your system. It will work better for everybody. There is no sense in building a building and then inviting the patients to pick out the paint color when what we really needed was a floor between the 5th and 7th floor. When the building's already built, there's no way that we can add that in. So let's work on designing this together. I think one of the key things for me in terms of building patient leadership is apprenticeship and mentorship. As I mentioned earlier, when one person is going alone, it's so easy for everyone to view and dismiss their ideas as too whatever. And it's a fear that individuals have of joining a change or a movement that they know they will not be the majority voice in. It feels scary. It's intimidating to go against, the swim upstream, basically. So create that infrastructure that supports teams of people doing this together to teach one another and create the space for learning and collaboration. What else? The last thing I think is to start with people who are already interested. It will just be easier. You'll go farther, and eventually I think most people will follow you. There are people who are interested. Just because you don't see them doesn't mean they don't exist. They're easy to find, and it's harder to change people than it is to find and invite and accept people who are interested in doing this kind of thing. So I think I will stop there. I know we wanted to have a discussion this morning, so those are just kind of some of my work and my thoughts on patient leadership, and I'm happy to have a conversation about it now.
Erin, thank you very much indeed. What a fantastic overview. And so one of the frustrations with the webinar format is that it doesn't particularly work well for giving speakers a round of applause, but I think we should still do that. So Erin, thank you very much indeed. I hope everyone joining in, whether you're watching live or recorded, joined with us in our round of applause there. And Erin, as well as I'm sure people want to give you a round of applause, I'm sure there's a huge amount of head nodding from our attendees as you went through there. I think a lot which really resonates with our context. And so we'd love people's reflections and questions. Anna, to remind people how to do that?
Sure, 3 ways. So please do post your questions using the question box facility on your screens. You can email us, hello@kaleidoscope.healthcare, or do join the conversation on Twitter @KScopeHealth, #long-term conditions, or SusHealthUK. I can see on the screen there now.
Lovely. Anna, thank you very much. And thank you. Questions already starting to come in. And Annette, I'm going to come to you for your reflections in just a second. But I'm going to steal Chair's prerogative just for a moment. To say, Erin, it's a fantastic story. Can you just give us a sense of the amount of time it took from first becoming involved in those conversations with clinicians and sort of realizing that onlyness, that role you could play, to actually this network happening? Because there's been real change here. This thing is now alive. It's actually there.
It is very much alive.
Over how long?
It's still very much a work in progress. I can't say that we are there. It's not that we've made it, but we've made tremendous strides. So I kind of started this back in about 2012. And I was kind of accepted and invited to participate probably maybe 2 or 3 years later. So it took a while. It took a lot of persistence. So there was a lot of tears involved in trying to kind of make sure that I could fight for what I just believed so deeply in doing, not just for myself, but for the rest of my community that I heard wanting to do this, but that didn't have the voice or the means or the courage or the whatever to stand up and say this to the clinical care teams. I think probably about 3 years ago is when I really felt like we had kind of made a big impact, when we had teams that were joining our network, and we were able to make one of the requirements that they had a paid patient or family partner on their care team as well. I think if I can say real quickly, one of the challenges with that was that we didn't have a great infrastructure for supporting the teams in what that should look like, what that means. We made the requirement, but we didn't say how we're going to help you support that. So the patients were getting paid, but there was still so much conflict because we've never worked together like this before. Patients were never working as paid members of the clinical care team before. So it was a challenge. And now we have all of this amazing data that we've collected over the last 3 years on the challenges of partnership, how to find the right fit, tools and resources for navigating some of this conflict that might exist. So it's still the short answer to your question, it's a long process, but there's so much learning that's happened every step of the way. And I've just been grateful to have this quality improvement experience that I can start to record and track and learn and improve faster.
Erin, thank you very much. Again, please do send to questions, reflections. Thanks to those who are doing so at this very moment. Annette, your reflections.
Thank you, and thank you, Erin. That was fascinating. I certainly heard a lot of things that really resonated, having worked in the health system for quite a few years now. I really liked your concept of onlyness and being one voice and trying to have your points and opinions validated in a sea of other people who don't view you on the same level of parity. And I think that's getting better in our health system, but there's still a phenomenal amount of work to do. And it's great to hear how you've sort of broken down those barriers over in Pennsylvania. And again, just seeing how you've managed to maintain and build the momentum. I think a lot of time people can come together in these collaborations with all the force for good, but really, as you say, having that infrastructure to maintain it and keep that momentum going is another really impressive aspect. And I guess for me, I'd just be interested to know how sort of far you could see this growing, how big you could see this getting, if you think there could be a point that would be unmanageable. And if you just, in your work more broadly, have seen any other examples of similar networks that you think, you know, that's another really great example that I'd love to share.
Yeah, thank you. Great question. So, Erin, your plans for world domination, I think,
yes,
is that, you know, how far is it going to go? But also other examples. It'd be lovely. I think you briefly mentioned you're sort of aware of that Cincinnati model. It's possibly talk about Cincinnati, but others you see in this space.
Yeah. So I don't think that it can get too big. I have big dreams. For us, I think our care center network has 120 centers across the US, and our goal is to network and connect all of them because there's still too much unintended variation in care and outcomes across our centers. And what keeps me awake at night is the fact that where you live determines what outcome you may have. And I'm not okay with that, especially in this information age where we can be connected to one another and learning all of this time. So I would love to see this grow across the whole country. Frankly, I would like to see it grow across the whole world because Sweden has a great registry model that we would love to embrace. And we're doing a lot of learning with the UK and the CF Trust as well. And we shouldn't have these crazy variations in life expectancy or age of death, or even things like access to medications. We can learn from one another, and it's just silly that we're not yet. So yes, total world domination is my goal. I think, what was the second part of your question? Oh, other networks. I've seen this in other networks. Improve Care Now for patients with Crohn's and colitis, and the National Pediatric Cardiology Quality Improvement Collaborative is another one where there's a tremendous amount of parent and patient leadership. It's in a different capacity. None of these other networks have, as far as I know, have paid parent and patient partners working on their care teams. I think that is unique to our network. But when you're resourced for success, you're more likely to see success. It was this idea of self-reinforcing power structures. And I wanted patients and parents who either could not work because of disability or caring for a sick kid, or just had a desire, you know, I no longer had a desire to work in marketing and marketing research. I wanted to work in what I was passionate about, and finding a way to be supported and funded to do that. I just felt like that was really powerful and important in our network. So I wanted to make sure that we weren't the volunteers who were squeezing in calls and finding time for work after our day job, between our breathing treatments, before we go to bed, but actually paid and supported to do this work as, you know, true partners in it. So there are other networks. We're learning from each other as well. There's a lot that we can learn from them and their different structures. There's a lot that we're trying to teach as well. But it is something I think that is slowly gaining momentum and growing. I'll just say one more thing about this. One of the challenges that I've seen in this is it feels easier to go alone. And I've seen a lot of patient organizations collect and organize communities of parents and patients who want to create their own registry, who want to collect their own data, who want to do whatever it is that they want to do. And they kind of go this direction, but the clinicians are still going this direction. And it becomes a problem. It's hard. There's resistance, and it is slow. It is painfully slow to go with clinicians and healthcare systems. But ultimately, you make greater strides at the end of the day if you can find a way to do it together.
Erin, thank you very much. Again, this is a webinar, but I can hear people going, yeah, exactly.
Yeah, the nodding resounding.
Erin, thank you very much. And I think questions flooding in.
They are. So yeah, let's turn to some of the questions. So thanks all for your questions and comments, and do keep sending them through. We had a comment from David on Twitter just saying that as a UK GP, patient pool is massively underutilised over here. And linking to that, John had a question for you, Erin, and he says, did you find your role as a patient advocate, or did you find in your role as a patient advocate that healthcare professionals viewed your experience as purely anecdotal? And if so, how did you change this view over time?
Yes, sometimes. It sort of would depend on who you were interacting with and kind of in what context. So very interestingly for me, there was still a huge line that was drawn between Erin, who was sitting and receiving advice and care from a doctor when my son was there with me, and Erin, who was there wearing the hat of your family partner. Even though the experience that I brought to the table was specifically because of this experience of sitting in the clinic and receiving care and interacting with you in that way. When I was sitting in the office, it was not received as anecdotal. My advocacy and the work that I had done in talking with the care team, it was very much valued. The data that I tracked on my son, the stories that I brought in from other patients in the community who might have tried, you know, X or Y treatment, and why I wanted to have a discussion about this. But when I would bring that into the conference room for a team meeting when my son was not with me, when I was there as the family partner, it just was kind of almost met with a funny silence. There's, you know, friends still joke about the fact that people don't know how to react to a comment that I might make or what have you. So it's just, there's a pause, and then we just go on to the next thing. They don't know what to do with it. So it wasn't totally dismissed. And I kind of realized over time that, like, even though we had those uncomfortable silences, people were hearing me. They just didn't know what to do with it right away. And slowly over time, kind of hearing it again and again and again, and starting to hear it from my partners that I was working with now, other parents and patients, then they started to use it a little bit more and try to bring it into their own practice. It's not that they didn't want to use it. It's not that they were straight up resisting it. They just didn't know what to do with it because it was brand new, and it was a little bit weird for all of us, and still can be sometimes.
Erin, thank you. Anna, more questions?
Yes, Ollie, thank you for this question. Ollie asks, so people with CF cannot meet in person, but parents of children with CF can. Do you feel that virtual collaboration platforms or tools are good enough to enable people with CF to participate fully?
Oh, I wish it was different. I do wish it was different. I feel like there's so much camaraderie that happens in person that I wish people with CF could participate. One thing that we've done, there is a great amount of technology that allows for more interaction than there ever has before, but it's still certainly a challenge. One of the things that we've been trying to do to combat this is, for all of our in-person meetings, we rotate through patient leadership who can come to the meeting. So we don't have one patient partner. I think half of our 70 patient and family partners are patients. And while they can't all be there, we're taking turns so that every one of them gets to be in that room. Additionally, we started rotating the parents to participate virtually so that we can understand what that experience is like as well, so that we're not just the only ones who are in person together all the time, kind of like, oh, sorry, we had a technology issue and we missed your point. Like, we need to be on that side too. We need to all find ways to do this in collaboration with one another. I know the CF Foundation just recently started some completely virtual conferences. I haven't personally participated in any of them, but I've heard great reviews of them, where everyone is participating virtually. All the presenters, all of the participants, every single person is on this, sort of like we are today. We're all online together interacting. And while you can't always hear the rounds of applause, you know, it's a step toward inclusion in, I think, what is otherwise a pretty isolating disease because of these restrictions around being together.
Erin, thank you. Anna.
Great. Gemma, thank you for this question. Gemma says, Erin, your story is inspiring. Do you have any thoughts on how to encourage patient or family input from those who are not as proactive about it as yourself? It sounds like it has been hard for you to get your voice heard, and do you think this puts a lot of people off?
Great question.
Yes, I definitely think it puts people off. I don't know, I was born without the fear of rejection, I guess, because I just kind of continue to show up and persevere. But it's hard. It's really hard to do. I will also offer that it is really challenging to live and work in this disease. It felt like there was never a break, and I've had to step back and take breaks from it at times. I think, you know, there's more than one way for people to offer their feedback and their input. And in order to find ways for them to do that, I think instead of just asking for it, instead of creating groups or spaces, I think clinicians often need to take a step into an uncomfortable space and find ways to just listen instead of asking. These conversations are happening all over the internet. Look on Facebook, follow different hashtags on Twitter, read patient blogs, listen to podcasts. These conversations are happening, and this feedback and this input exists. It's not something that you need to create or find. You just need to accept a little bit of it. And I think it's happening more than you realize among people who are not like me. So I would say, in order to find people who are like me, they don't have to be doing what I'm doing. They have to find a way to do what it is that they do. And maybe that's just coming to clinic and feeling comfortable to have a conversation with their doctor, right? Maybe they're the people who aren't regularly, adherent to their medications or whatever. Maybe it's somebody who writes a blog. Maybe it's somebody who fundraises. But kind of acknowledging and supporting whatever effort it is that they're doing in their chronic illness care and capacity that they have is their own form of advocacy. It doesn't have to look like what I do for it to be powerful. So I think that's probably my best advice for to answer that question.
And I think it's a really powerful point that this model of co-production is uncomfortable for pretty much everyone. Yeah. And that we shouldn't pretend that it's not, at least initially. So it is a new way of thinking, a new set of skills required on both sides to make this partnership work.
Absolutely. I remember a funny conversation that I had when I first started working with the clinical care team, and they said, these meetings are tough because, we're talking about really sick patients. Like, we talk about morbidity. I thought, I live with that every day. Probably more than you do. You talk about it in your hour-long meeting, but I have a child that I live with we face this every single day. We have more in common. We realize and experience more of this disease than anybody else does. And we have this wealth of knowledge that we can share with you to help make things better for both of us. I can help you to help I can help you take better care of me if we can find a way to make it through some of these uncomfortable conversations. But it's at times felt like pushing a giant rock, boulder up a hill. It just like, all right, get back up, go at it again, give it another try.
And Erin, I did see on Twitter that you tweeted a while ago that you can't stand the term patient engagement. And it'd be nice to come back to that in 1 second. So I'm sure that'd be a good conversation to have. But Anna, questions?
Yes, Ollie, thank you for this question. Ollie asks, does your funding restrict your freedom to operate in the way that you would like to?
Yes, totally. It's been a double-edged sword a little bit. I want, and I'll be honest with you, there are certain things that I've kind of kept doing outside of my funding because I want control over it. One of the things is the website that we created for the CF Learning Network. It's not cheap to run and update, but I feel like it is important enough to inform the patient community of the work that we're doing, of our successes and of our failures, which not all of my partners agree with. Some people feel like it should be success only that's shared. And I just don't believe that kind of fundamentally. And so I will not put that underneath the scope of what is funded. I keep that all to myself. There are certainly other challenges. I think a fundamental challenge of the way that the Cystic Fibrosis Learning Network is set up compared to the way some of the other networks are set up is that for most of the other networks, centers pay to participate. They throw money into a pot and then they all co-own the network and they all kind of co-run the network. In the Cystic Fibrosis Learning Network, centers are paid to participate. Their participation is supported, it was subsidized by support from the Cystic Fibrosis Foundation, which is amazing that we have a great funding stream and people feel accountable to this organization. So for me, sometimes we struggle with that because it feels like it's still power is up here coming down to the centers versus power is here and it kind of spreads out to everybody. So both for myself and for the teams that are involved in it, I think it's tricky. I don't know if centers would continue to participate if there was no funding for their participation. But hopefully we continue to learn and figure out what the best model is. Like I said, our network's the only one that pays patients and parents, and that's funding that comes from the Cystic Fibrosis Foundation. And we're grateful to have the opportunity to do something like that. I hope that centers who are parts of networks that are paying to participate can find a way to subsidize the cost of their patient participation for people who want it. Not everybody wants it. Not everybody wants to be paid. Some people want to be volunteers, and that's totally fine too.
Erin, thank you very much. We've got about 10 minutes or so left. We're rushing towards 2 p.m. here in London. So just a reminder about how to join in, Anna.
Yep, please do keep using the question box facility on your screens. You can email us hello@kaleidoscope.healthcare or join the conversation on Twitter @KScopeHealth, hashtag long-term conditions.
Excellent, Anna, thank you very much. We've still got questions coming through.
We do, and one links to your previous question, Rich, so that works quite nicely. Lynn, thank you for this question. So Lynn says, I saw the engagement tweets and I'm interested to hear more about this and how Erin feels about the term patient empowerment. Also, how you feel about the overuse of the word patient when we are all in fact people.
I have a whole lot of thoughts on this. You'll have to tell me to cut it off at some point if I go too deep here. The tweet that you all are referencing, I said, I hate the term patient engagement. No one is more engaged or involved than the patient. I want clinician and researcher engagement in what I'm doing. And I truly mean that. And I want to make sure that it's understood, though, that it's not a blanket statement for everybody. I certainly believe that at the individual level of care, there is a huge opportunity for clinicians to invite and try to engage patients differently in their care and outcomes. My tweet specifically is in my role and in my work at the conferences that I attend or at different speaking events and stuff that I might do when people are talking about like, how do we engage patients like this? How do we find and engage speakers and what have you? And the problem I think is that you're rather than inviting people to talk about what they're passionate about and inviting their wisdom and expertise and knowledge, we're trying to fit this square peg into a round hole. And inviting what they actually know and have is crazy amounts more powerful, right? Like if you all had come to me and said, like, we'd like you to talk about Kaleidoscope Health and AbbVie and this specific, I would have been like, I don't have anything. I got nothing, right? But can we talk about patient leadership? Yes, you heard. That's what I'm passionate about. That's what I've tried to build and grow in and among my communities. I think something we often struggle with in these organizations, because there's not a great patient organization, is trying to find ways to get folks to engage with the patient community, because it is kind of vast and disorganized. But that's my point earlier of going online, listening to podcasts, reading blogs, engaging in the conversations. There's this general fear that, you know, clinicians cannot be a part of Facebook conversations or Twitter conversations, and, you know, the information shared online is not always accurate. Well, absolutely, because the conversation's not balanced. It's a bunch of informed, engaged parents and patients using our experiences, but wouldn't it be nice if we could complement that with clinical knowledge and expertise to have a more balanced conversation around things? So I do wish that there was more opportunity to have institutions and pharmaceutical companies and everybody kind of step outside of what they've identified as the priorities and the topic areas that they want to discuss, and really start listening and paying attention to what it is that patients and parents are talking about, and try to build resources and curriculum maybe around those topic areas. Patient empowerment, I think, kind of falls into the same camp. Again, at the individual level of care, absolutely. There are, I'd say I'm like the 1% of the 1% when it comes to, you know, individual care and stuff. I recognize and accept that most people are not like me. And we do need strategies to engage them. Again, listen, I think, more than you ask. They're telling you more than you realize a lot of the time. And frankly, I don't, to the last part of the question, I don't mind the term patient, because we're really talking about my work in caring for my son as a patient, not my work in caring for my son as a mom. There's a lot of intersection across those two roles. But, you know, I try to talk about people with cystic fibrosis, not cystic fibrosers or whatever. You know, CFers, or people might call them. And so I think it's just important to pause for a second and think about the context that you're using that information in. When I'm in the doctor's office, I'm a patient, you're a patient. We're all, this notion that we're all patients is fine. Chronic illness is maybe a little bit different. Like, we're not all chronic illness patients. We don't all experience the joys and horrors of the care system the way that people living with chronic illnesses do. And a lot of people are living with chronic illness. So I think just think about the context that you're using the term patient in to figure out if it's the right spot.
Erin, thank you very much. I think there's going to be a whole host of people now who are going to tweet you every time they're unsure about using a term, going, Erin, is this all right? Erin, thank you. We're fast running out of time. Anna, question?
Yes, we have one last question. David, thank you for this one. And David says, Erin, you mentioned quality improvement training materials for patients, and just, do you know whether these are available to patients in the UK, or where can these be found?
Absolutely. There's we created, our quality improvement consultant and one of our parents created these quality improvement videos that are on our website. I think you shared the link to our website, and you can certainly look, you're welcome to tweet that as well. It is open and free. There's a section on the website called Community Innovators, and under Community Innovators is quality improvement training. I think that might not be exactly the right term, but they're on the website, and it's just a series of, I think there's 7 videos that go through the different parts of quality improvement, from, you know, setting your aim and doing PDSAs and all of these different little steps in short videos that anybody, it doesn't have to be just patients, anybody can look at and utilize on their own time. You don't have to join a 6-month-long class. You can watch one video here and one video there, and start to try to use some of these tools to learn a little bit more about quality improvement. But absolutely, anybody can. It's free and open. I want to free all the data.
Erin, thank you very much. We're a couple of minutes away from closing, so we'll move very shortly just to final reflections. Just to buy my fellow colleagues time, I'll go first, then Anna, then Annette, and then Erin will give you the last word. But just to say, as we mentioned earlier, that today's webinar is part of a series of events all thinking about how change can be made around long-term conditions, some of their practical nature, some tips and tricks around making change in a difficult context. If you'd like to find out more about those events, if you go to kaleidoscope.healthcare/change, we'll put that link in the chat box as well, so you've got that. Please do come and join us. We've got face-to-face events. We've got one more webinar, Anna, coming up on the something of November, so we hope you can join us for that one. We'll confirm that date in just a moment. So if you've enjoyed today, please do join us for future events. So final reflections. So I'll start. So Erin, I was really struck by your point. That's where you said it sometimes it feels easier to go alone, and I think you really do see that. You sort of get people who are committed, and so you have a clinical group or you have a patient group, and it might be easier, it might be less painful. But I'm completely convinced by your point that if you're wanting to make change, you've got to involve, you've got to get yourself into that uncomfortable space where you cross some of those boundaries and get people working together. I think that's quite challenging to how a lot of us work. And so I think real food for thought about how you embrace the uncomfortable, because you're going to have to at some point. Anna.
Thank you. Yeah, Erin, I really liked your reminder that all people involved in the care system should be involved in designing the care system, and that for people with lived experience, that means that your experience is your expertise.
Thank you, Anna.
And I really like the point, sort of similar to yours as well, Richard, that for people to be really able to engage in this, they need to not come at it from their own priorities, but really look at it from the perspective and priorities of the people they're trying to engage with. That's something we can look at when we think about how we can spread good work across the system going forward.
Thank you very much. And Erin, you have the floor for the last word.
I mean, it's very much in line with what you guys just offered, and it's seeing the kind of the tweets and the responses of the people who were tweeting about the webinar before the webinar, the questions we've gotten during the webinar, your reflections. Everybody seems to want to do this, and people just don't know how. And so rather than letting kind of perfect be the enemy of the good, just take the first step. Take the first step, be uncomfortable. Remember that, you know, like I said, not everybody's like me and willing to kind of wade into that discomfort to start these conversations. And so if you have the courage to take that first step and be a little bit brave and, you know, risk being rejected or feeling uncomfortable just for a few minutes, I think it really pays off. It's really paid off for me. And I think it can really pay off for a lot of people in a lot of ways. I think you've probably all heard it too, the questions that even came in during the webinar. People are interested and curious about this, and they just don't know how to do it. And so my parting advice to you would be just start, just do something.
Erin, thank you very much indeed. We are out of time. Thank you everyone for joining. And I cannot believe, if you've joined us over the last hour, you're not going to spend the rest of your day slightly more energized, inspired, and probably going to do exactly what you said, Erin, and go and actually do something about it. If you are, please tweet us, let us know. We'd love to know how you take this forward in your context. We will end there. Thank you, Erin. Thank you, Anna. Thank you, Annette. Thank you all, and we hope to see you again on a future webinar. Thanks all. Bye-bye.